Good morning, good day, and good evening, everyone. My name is Fabian Proft. I'm a member of GRAPPA and currently have the honor to lead Y-GRAPPA. It is a pleasure today to have here Laura Coates. She's an associate professor from the University of Oxford, and she was tremendously leading the GRAPPA management and treatment recommendation update. So, Laura, it is a pleasure to have you here and to get your insights about the management and treatment recommendation update. Thank you, Laura.
I'm very happy to talk you through them. So I'll share some slides just to run through the recommendations as they've been published recently. So this is the third edition of the GRAPPA treatment recommendations published just a few weeks ago, but from the update in 2021. And these are my disclosures. So the aim in the GRAPPA treatment recommendations was to provide an update on the recommendations that were first published back in 2009. And you can see here that the goal hasn't changed. Our aim as a research organisation is to develop guidelines based on the best scientific evidence for the optimal management of patients with psoriatic arthritis. And to do that, we aim to take in current approaches to guideline formulation, high ethical standards, analyse the best available evidence, and incorporate diverse stakeholders into the process so that we can create patient-centric treatment recommendations. So as you can see here, the main change that we made at the start of these recommendations between 2015 and 2021 is we split out the comorbidities group, shown in orange at the bottom, into two separate groups, a related or associated conditions group who dealt with inflammatory bowel disease and uveitis, and then a separate comorbidities group who dealt with the other comorbidities. But you can see in terms of the other groups, these remain the same, with very much a stable domain-based approach as we used in 2015. There were three of us who led the GRAPPA treatment recommendations, myself, Artie Kavanagh, and Enrique Soriano, and we worked with two methodologists who supported the systematic literature review. We then had two domain leaders in each of the domain groups, plus at least one patient research partner per group. The GRAPPA members were invited to join domains of their choice, and we aimed to get between 15 and 20 participants per group. The patient partners sorted themselves into the groups, depending on where their interest was and what they had direct experience of. And then at the end, the recommendations underwent review and voting by all of the GRAPPA membership, with around 170 respondents, of whom just under 10 were patient research partners, and we've shown their votes separately so that they are not lost in amongst the clinician votes, and 161 clinicians. So we start off with the overarching principles. Number one here is an addition, and it's just an introduction to the recommendations that's new from 2015 to explain where the recommendations come from. The principles 2 and 3 are exactly the same as they were in 2015. You can see here I've highlighted the changes in some of the wording to the overarching principles. We aim to be a bit more specific around which comorbidities we were covering and cover a wider variety of comorbidities in this version. And we made very minor changes in the overarching principle here to highlight the fact that a lot of patients will be cared for by clinicians who are not necessarily doctors, so specialist nurses and other members of the healthcare team. We also added two position statements, and these were applicable across the different domains and were new to cover, I guess, key topics that we thought were crucial for clinicians working in this current time. So the position statements on biosimilars is there to try and support clinicians and patients and give hopefully very sensible, pragmatic advice about the use of biosimilars so that we can use these and hopefully save costs within the healthcare setting, but then ideally, hopefully improve access for a larger number of patients. And a second position statement was entered around tapering and discontinuing therapy. There's increasing observational evidence and some newer RCTs looking at tapering and reducing treatment. And we wanted to provide support for clinicians and patients around this, and particularly ensuring that that's done under a shared care decision-making process. When it came to the main methodology of the recommendations, we followed the grade recommendations. We developed PICO questions within each domain group, looking at the population, the intervention, the control, and the outcome. We then did a systematic literature review update, focusing on randomized controlled trials and updating from the SLR that was performed back in 2013 for the 2015 recommendations. We extracted the data from identified papers using a lot of GRAPPA members and the methodologists, and graded the quality of evidence of each of these papers as high, moderate, low, or very low. And the final grade recommendation is based on these things, but also a lot of other items. So the design of the study, any limitations, any inconsistency in results or indirectness of evidence, and any bias that's perceived in the studies that we used. And then those grade recommendations can either be for a treatment or against a treatment. And each of those, that can be a strong recommendation, so you should offer this drug, or a conditional recommendation to consider the drug. So this is the search strategy. We searched from February 2013, which is where the full SLR went up to last time. And we performed the first search on the left here in November 2019. But then obviously, just as we were about to extract the data, COVID hit. And so we updated the search on the right-hand side in August 2020 to ensure that we were as up-to-date as we could be. And you can see that included looking at Medline, Embase, and Cochrane, but also looking at abstract searches to pick up new data that haven't yet got into fully published papers. And all of that was extracted out into a data library with the efficacy and safety data extracted for each of the key disease domains. We did some additional searches for the related conditions and comorbidities group, looking at treatment choice in comorbidities, screening for related conditions and comorbidities, RCTs for the treatment of uveitis and inflammatory bowel disease, and looking at prognosis and phenotype in related conditions and psoriatic arthritis. And that's because they really weren't covered by the original searches. So we came up with this evidence table as a first step with each of the domain groups. So you can see here down the left-hand side, we've got the indication, and this is split for some of the groups where we have more evidence into patients who are DMARD naive, patients who are DMARD inadequate responders or biologic inadequate responders. And then across the top, you can see drugs that have a strong recommendation for their use, conditional recommendation for their use, and then conditional strong recommendations against use, or where there's insufficient evidence and there's still a question. So this summarizes the evidence here. You can see obviously that we have new mode of actions that have joined the family of treatments for psoriatic arthritis since the recommendations in 2015. That particularly includes the use of IL-23 inhibitors and JAK inhibitors. We've got a bit more evidence for conventional DMARDs in peripheral arthritis from studies like the SEAM study. And you can see here on the axial, we've got now the addition of JAK inhibitors for use of axial disease. And under insufficient evidence, we've got the IL-12, 23 and IL-23 inhibitors who have some positive PRO data in PSA, but negative trials in AS. So we're waiting on further evidence. In enthesitis and dactylitis, again, you can see inclusion of those new mode of action drugs, but also an inclusion of data for methotrexate as a conditional recommendation based on the SEAM trial. We've got treatments for psoriasis and nail psoriasis here, as well as quite a few with limited evidence in the nail domain. And then finally, because of that split in the comorbidities group, we've separated out the data on inflammatory bowel disease and uveitis, and we can show here the drugs that we would use for psoriasis and psoriatic arthritis, and whether these are recommended for the use in patients who have IBD and uveitis as well. This isn't a full review of all treatments for IBD and uveitis, that's beyond our scope, but it does include the drugs that you would typically use in psoriasis and psoriatic arthritis. And then we put all of that together into a treatment schema, which you see here. You can see the 6 key domains on the left of this slide. On the right in the orange is the data for IBD and uveitis. And just as before, what we're aiming to do is think for any individual which domains are involved, whether there's a patient preference, and then choosing a therapy that should address as many active domains as possible. So you pick your therapy using the different domains that are active in that individual, consider comorbidities and related conditions to choose a treatment, and then treat the patient, reevaluate the treatment goals regularly, and modify therapy as required. So we have our main recommendations now published in Nature Reviews Rheumatology. These are open access, so they're available to all. The underpinning individual domain papers will be published shortly in Journal of Rheumatology. And GRAPPA are also working on developing a patient version of the recommendations, and that's being led by our patient partners. We've got an extensive dissemination plan to try and share these, and hopefully this video will be part of that plan to share the recommendations as widely as we can with clinicians and patients across the world. Thank you very much.
Perfect. Thank you, Laura. Thank you for your insights and just running us through this, because I think, as you said, the dissemination is of high importance to make the people who are using the drugs and the treatments in their daily life they are really aware of what is going on and what we are as a society recommending. And I think there are some thoughts, and maybe you can just highlight them. First, I think it was really important to also include the associated comorbidities now here, because this is something that we really face in our clinical routine, right? That we have a patient that is not only having PSA, but we need to take into consideration which of the medications is also effective for the IBD that this patient is having, or also the recurrent uveitis that was there. So it was a very concise and brilliant presentation that you give, but maybe you can highlight and summarize the key novelties of the 2021-2022 update in regards to the previous version from 2015.
Yeah, so I think there's that addition of the related conditions, as we've discussed, and that's now come into the main figure, which is a big difference from last time when it was in a separate table. Obviously, things have moved on. We've got new evidence, which is great. We've had the first specific trial in axial PSA showing efficacy of IL-17 inhibitors. We've got the availability and wider evidence for IL-23 inhibitors and JAK inhibitors. So they've been included into that treatment algorithm. And we have got still a small amount, but an increasing number of more strategy trials, looking at comparing conventional DMARDs with biologics, head-to-head studies comparing different biologics. And so that helps us in terms of selecting therapy. We're still a bit lacking in data comparing a lot of different treatment approaches. There's a lot more to be done, but we have that initial data from the head-to-head trials. And as you mentioned, actually, for peripheral arthritis, pretty similar outcomes across most of our biologics, but it's other domains of disease where we really see the difference. So differential efficacy in psoriasis, in axial disease, and then considering related conditions like IBD and uveitis.
Perfect, thank you so much. And you also highlighted that we need to take the patient preference also into account, and I think this is also something very important that we should highlight here again. And as we all are familiar, there are also other recommendations, the Euler recommendations out there. They differed more in the past, because I think this was very unique about the GRAPPA recommendations with the domain focus. And we all know that the Euler recommendations got closer, but maybe you can highlight the still existing differences between the new GRAPPA treatment recommendations and the existing Euler treatment recommendations.
Yeah, so I think, like you say, they are a little bit more similar. They have clearly considered enthesitis and axial disease as separate domains because of the differential efficacy. Some of the differences between Euler and GRAPPA are because we have included more recent evidence. Obviously, the Euler recommendations now are from 3 years ago, And so, things have changed. So we've included more data on JAK inhibitors, for example, in axial disease. We had the data from the SEAM trial looking at methotrexate in enthesitis and dactylitis. So part of it is just that the evidence has moved on. And actually, if the Euler recommendations were done at the same time, they may be even more similar. I think the other difference is around advice about hierarchy of medications. So GRAPPA has typically taken the stand where if there isn't head-to-head data, but there's data of efficacy for a number of drugs, we leave that quite open. And that's particularly because we're aiming at an international audience. And we know that accessibility of different drugs is going to vary quite a lot in different healthcare settings. Euler have typically been a little bit more prescriptive in the drugs that they recommend, or in a hierarchy of drugs. But again, it's quite similar. And actually, in the latest update for Euler in 2019, they included TNF inhibitors, IL-17 inhibitors, and IL-12/23 inhibitors, all at a similar level for patients with peripheral arthritis.
Perfect. Thank you so much for these insights. And you also mentioned already that the systematic literature review was until, I think, the beginning or August 2022 was the last version, right? So 2 years ago. So when do you expect that the next GRAPPA treatment recommendation update will appear, and what would you foresee what will be included as novelties and new evidence?
Yeah, so the depressing thing about writing recommendations is that they're always out of date by the time they're published. There's always new data coming through. I think to some extent, we've future-proofed a little bit for the drugs that we know around the corner, because we've offered recommendations on mode of action. So there are, for example, new IL-17 inhibitors coming out, new JAK inhibitors coming out, but they have almost been included in their family of drugs. Obviously, we'd love to do this as frequently, as once a year. There was talk at the latest meeting about having an annual update, but that is a really big commitment to do. And doing that alongside everybody's day jobs is quite tricky. I think one of the advantages, again, partially caused by COVID, is that we seem to have now moved out of step with Euler. So in 2016, we both published recommendations at the same time. Euler's update came just before COVID. Ours has now happened just after COVID. So I think there's a really big advantage that if you do have multiple sets of recommendations, aiming at a slightly different but clearly an overlapping audience, I think it's nice that if you have them staggered, then you do have some international recommendations taking into account that newest data as regularly as we can. We have talked about doing brief updates through GRAPPA as well. So maybe not a full recommendation, but a kind of brief update if something big and new comes on the scene that we think would change how the schema and the evidence table would look.
Perfect. So I have two questions for this. First, this is more a remark, because you have also included Congress abstracts. So I think this is somehow improving the fact that you mentioned that as soon as the recommendations are published, they are already outdated. So I think this was one very important point to mention. And because just recently at the Euler, we saw data about IL-17A and F dual inhibition. And would you foresee that they are then included in the IL-17 family, or rather split, that there's a differentiation?
Yeah, so we made a decision back in the 2015 recommendations that we would include abstract data, but be clear if it was only abstract data that it would be a conditional recommendation, so not quite as strong. We've had a lot of debate about which drugs you include in a family. So do you include JAK inhibitors as one group? Does a TYK inhibitor fit into that JAK inhibitor group? Do dual IL-17A and F fit in with the IL-17A group? We took the decision, and that's in these recommendations, that where we can, we will group them into mode of action unless there's good evidence that actually the efficacy is different and they need to be considered separately. So I think for the moment, we're including drugs like bimekizumab in that IL-17 group. But if there is more data in the future that says that actually some of these drugs aren't quite the same and we need to split them out, then we would do that in future.
Perfect. Thank you so much. And as we all know, one of the most interesting and vibrant discussions is always going on about the research agenda, because here everybody has maybe also different kind of thoughts, what should be highlighted, what should be prioritized. And maybe you can share some of this debate and discussion points with us. What is on the research agenda and what can we look forward into for the future?
Yeah, so we tried to be inclusive, and we reached out to a number of our guideline committee to ask for their suggestions and input about what should be on the research agenda. And as you say, it's very broad, really. We're thinking in terms of management, from everything from screening and early diagnosis, potentially preventing psoriatic arthritis in those who have psoriasis, then moving into the actual drug treatment arena, so treatment strategy trials, information around treat to target and different approaches in the clinic, as well as comparative studies. As we've mentioned, we have now got some head-to-head studies, but still quite limited numbers. And we'd love to see more evidence looking at different sequencing of drugs, strategies of combinations, treatment escalation, that different kind of approaches. And then I think the other area where we're really lacking good quality evidence is around the comorbidities. You could see we had to do extra searches because there aren't really any RCTs in that field, at least outside IBD and uveitis. And even in IBD and uveitis, that doesn't look at patients specifically with PSA. It's just patients with IBD and uveitis more generally. And thinking about other comorbidities like heart disease, diabetes, metabolic syndrome, there's clearly a lot of evidence gaps in how we use that information to best treat patients.
Perfect, Laura. There are no more questions from my side. This was a perfect and insightful discussion, and thank you so much for your time and for your presentation. It was a pleasure having you here, and I can only say thank you again. And yeah, enjoy the rest of your summer, and it was a pleasure having you here. Thank you, Laura, and goodbye.
Thank you very much.